how probability interacts with possibility, interacts with practicality. With me as an example. So recently I've been seeing some doctors for my nose and throat issues, and I've had a lot of different opinions. Well, I mean, not that many, I guess, but a few. And I find a very interesting thing is thinking about the idea of probability versus what is most plausible versus what is really happening and how to investigate these things. So the first thing to know is that we can test for a lot of different things. Most often we actually don't, but we can if we choose to. However, as you do more and more testing, you get into more and more risk, as in there's possible consequences to these things, including one testing method that's called trial and error, or therapeutic trial. Sounds better, but try a medicine and see if it works. Because most medicines, a lot of them are not that harmful. And one common way to use this is trying antibiotics. This person has something on their imaging setting for their lungs. They haven't had any infectious symptoms. It doesn't sound like pneumonia. Well, potentially it could be. Why not just give them a course of antibiotics and repeat the imaging study in a few weeks or a month? See if it's improved. See if it's gone away. Then you think it's probably infectious, gone away. Now, it could be that it would have gone away anyways without taking any antibiotics. But we give antibiotics because it's easy. We're trying to do something to see if we can make a change. However, it has risks. Somebody could potentially be allergic to antibiotic, have life-threatening reaction. So it's not without risk, it's just very low. Now, as you get into more studies, right, you think about the risk of studies. So a CT scan, some radiation. A biopsy of the lung, that's potentially more risk. You could poke a hole in there, you know, with thorax, get bleeding, all these things. So we don't diagnose pneumonia by getting a sample from people's lungs. I mean, most of the time, 1% or less than one we do. And why is that? Because we think antibiotics are low risk. We just treat them just in case it is. Possibly is. It probably is. Regardless, we just give antibiotics. Now, the thing is, when you have something that doesn't make the most sense, and you have other information that provides additional, I would say, questioning, then what do you do? In my case, I was thinking about this because two ENT doctors were convinced that I have reflux, heartburn, GERD, whatever term you want to use, but I actually don't have symptoms of that. And I actually just had a EGD looking at my esophagus, and it was normal. There's no signs of damage from reflux. Now, it's possible I still have it, but how do I know? I mean, they gave me some medications where they're pretty harmless, so I took them, not improving. I know it's gonna take a while, but I actually feel worse. I don't know if they're medications that are making me feel worse or what's going on or this or that, but could it be that I don't have what they thought I would had? How do you know things? They took a look saying, "Oh, this has been a long time." It makes sense to me. I have a lot of cobblestone, a lot of inflammation. It doesn't happen overnight. Asked my doctor, "Do I need a biopsy if it doesn't improve?" She's like, "I don't think it's cancer." Why don't you think it's cancer? Because of the way it looks, right? Do you know it's not cancer? Can cancer look in different ways? And that gets into a more complicated issue. And that's the issue that we've dealt with for hundreds of years, and that's phylogeny. So the idea is that we have a certain appearance, but our DNA may be this or that, right? People with different DNA may present differently. People with the same DNA may still present differently. People with different DNA may present the same. All that is to say, in short, you don't know what's inside somebody, right? Somebody may smile for a different reason than somebody else. We all understand this concept. So just because somebody's smiling doesn't mean they all have the same feeling inside. We all know that. And that's the same with the body. It may look the same, but it may not be the same inside, right? Someone may have this growth on their head, and this person may have a growth that looks exactly the same, but one person's may be cancer and another person's may be non-cancer, because you just don't know what's actually going on inside. You don't know what's going inside someone's head when they do an action. Two people could do the same actions and have different reasons, different things going through their brain. And that's the difficulty with how things look. You could be right 90% of the time, but you could be wrong 1%. And that's just the thing. We miss stuff. We all do. We all make judgments on other people we never met. And we are right most of the time, but we could be wrong that 1% of the time. And if you're a patient, do you care if somebody's wrong? Do you want to be that 1% who's missed and say, that's fine. They don't miss that many, right? Or do you want not to be the one that's missed? I think that's the difficulty, right? As a doctor, I know more than most patients. So do I want to do some more studies? Do I want to be more sure than the average patient, right? The doctor may tell the average patient that I'm sure when they're 95% sure, because that's what their definition of sure is. Do I want the doctor to be 99% sure, 99.9? And I think that's the difficulty, right? When do you say, oh, it's no big deal versus it is a big deal versus let's definitely look into this? Where do you draw the line? And I think that's something interesting when I think about it myself. From both sides, right? As a doctor, when I work in clinic, I realize we're dealing with population management, not treating everybody to the optimal best ability that I have, because I can't do that for every patient. The system doesn't do that for every patient. That's just the truth. But when people get worse, I should look into more, right? We do more and more resources. That's the way it works, right? Clinic, minimal resources. A lot of things you can't see a specialist directly. Referral. Did you do this? Did you try this first? Get to the hospital. You want to see a specialist? Well, let me just call them. They may not see the patient in different models. At least I could call them and talk to them, get some information. Resources. We spend a lot more on patients in the hospital, and that's the way the system's designed and developed. Is that the right thing? I don't think so. That is the way it is. But when you know more, do you accept that? Do I accept that when it reflects upon myself? I don't know the answer to that question. I'm discovering it as I go along.